Hi, in this video we will talk about febrile seizures from Nelson's, chapter number 633, page number 3595, starting with febrile seizures. Febrile seizures are seizures that occur between the age of 6 and 60 months of life. Peak is between 12 to 18 months with a temperature of 38 degrees Celsius or 104 degree Fahrenheit or higher that are not the result of CNS infection or any metabolic imbalance. Fine, there is no CNS infection and any metabolic imbalance, and it occur in the absence of history of prior afebrile seizures. There is absence of history of afebrile seizures. A simple febrile seizure is a primary generalized, usually tonic-clonic attack associated with fever lasting for maximum of 15 minutes and not recurrent within 24-hour period. This is the simple definition for simple febrile seizure. What is simple febrile seizure? Which is primarily generalized, usually tonic-clonic, associated with fever and lasting for a maximum of 15 minutes max, and it does not recur within a 24-hour period. This is simple febrile seizure. Now coming to the complex febrile seizure. A complex febrile seizure is a more prolonged. It is more than 15 minutes or is focal or recurs within 24 hours. Okay. Febrile status epilepticus is a febrile seizure lasting longer than 30 minutes. Febrile status epilepticus is a febrile seizure lasting longer than 30 minutes. Okay, if a febrile status epilepticus seizure when lasting longer than 30 minutes, most patients with a simple febrile seizure have a very short post-ictal state and usually return to the baseline normal behavior and consciousness within minutes of seizure. Febrile infection-related epilepsy syndrome, that is FIRES, is a very different disorder seen predominantly in older, more than 5 years of age, usually male children. FIRES 1, in which there is a febrile infection related epilepsy syndrome, predominantly it is seen in more than 5 years of age, usually in the male children, and associated with encephalitis like illness but without a identifiable infectious agent. Children with the FIRES were previously normal but subsequently developed difficult to treat epilepsy. Between 2 and 5% of a neurologically healthy infant and children experience at least one, usually simple febrile seizure. Simple febrile seizures do not have an increased risk of mortality even though they are concerning to the parents. Complex febrile seizures may have an approximately twofold long-term increase in the mortality rates as compared to the general population over the subsequent 2 years, probably secondary to a coexisting pathology. There are no long-term adverse effects of having one or more simple febrile seizures. Compared with the age matched controls, patients with the febrile seizure do not have any increase in the incidence of abnormalities of behavior, scholastic performance, neurocognitive function or attention. Children who develop later epilepsy, however, might experience such difficulties. Febrile seizure occur in approximately 30% of those experiencing a first episode and 50% of those in 2 or more episodes, and 50% of the infants younger than 1 year of the age at febrile seizure onset. Several factors affect the recurrence, which will be discussed in the table. Although approximately 15% of the children with the epilepsy have febrile seizures, only 5% of the children who experience febrile seizure proceed to develop epilepsy. Okay, only 5% of the febrile seizure develop epilepsy. There are several predictors of the epilepsy after febrile seizures. This is an important data, that although 15% of the children with epilepsy had febrile seizure once, only 5% of the children who experience febrile seizure proceed to develop epilepsy in the later life. Genetic and the other factors leading to the febrile seizures. The genetic contribution to the incidence of febrile seizure is manifested by a positive family history of febrile seizure in many patients. In some families, the disorder is inherited as an autosomal dominant trait, and multiple single genes that cause the disorder have been identified in such families. However, in most cases, the disorder appears to be polygenic and many genes predisposing to it remains to be remain to be identified. Genes associated with the febrile seizures include SCN1A, SCN1B, SCN9A, and CPA6. In terms of other etiologies, a dysregulation between the pro-inflammatory interleukin 1B, interleukin 16, interleukin 8 cytokines, and anti-inflammatory ILR1A cytokines has been associated with the febrile status epilepticus. A decreased ILR1 and ILR8 ratio, suggestive of an overall pro-inflammatory state, is predictive of hippocampal abnormalities on the MRI done after the febrile status epilepticus. ILR1A or 1/8 ratio may thus provide the potential biomarker for identifying the febrile seizure patient who may be at higher risk for developing the mesial temporal epilepsy later in the life. So what we read in this paragraph, there are certain genes associated with the febrile seizures also. Fine. Risk factors for recurrence of febrile seizures. Major, these are the risk factors that we should know, that in children there is higher risk of recurrence. If the major ones are, if the age of the children is less than 1 year of age, duration of the fever for less than 24 hours, and fever of 100 to 102 degree Fahrenheit, then also the child had seizures. These are the major risk factors, and the minor ones are family history of febrile seizure, family history of epilepsy, complex febrile seizures, daycare, male gender, low serum sodium at the time of presentation. These are all the minor risk factor for the recurrence of the seizures. Now the risk of the occurrence of the subsequent epilepsy after a febrile seizure. Simple febrile seizure, 1% chances. Recurrent febrile seizure, 4% chances. If there is a complex febrile seizure that is more than 15 minutes in duration and recurrent within 24 hours, 6% chances of subsequent epilepsy. Fever for less than 1 hour before febrile seizure, 11%. Family history of epilepsy, 18%. Complex febrile seizures which are focal, 29%, and neurodevelopmental abnormalities, 33%. Almost any type of epilepsy can be predicted by febrile seizures. A few epilepsy syndromes typically start with febrile seizures. These are generalized epilepsy with the febrile seizure plus severe myoclonic epilepsy of infancy, that is Dravet syndrome. So these kind of epilepsy, they typically start as febrile seizures. Okay, which ones we need to know? They typically start with the febrile seizure. First one is the generalized epilepsy with the febrile seizure plus, and second one is the severe myoclonic epilepsy of infancy, that is Dravet syndrome. And in many patients, temporal lobe epilepsy secondary to the mesial temporal sclerosis. This GEFS plus, that is generalized epilepsy with the febrile seizure plus, is an autosomal dominant syndrome with a highly variable phenotype. Onset is usually in the early childhood and the remission is usually in the mid-childhood. It is characterized by multiple febrile seizures and by severe subsequent types of the afebrile generalized seizures, including the generalized tonic-clonic, absence myoclonic, atonic, or the myoclonic aesthetic seizures with a variable degree of severity. A focal febrile seizure plus epilepsy variant in which the seizures are focal rather than the generalized has also been described. Dravet syndrome is the most severe type of the phenotypic spectrum of the febrile seizure associated epilepsies. Fine, so this Dravet syndrome, this one is the most severe type of phenotypic spectrum of the febrile seizure associated epilepsy. It constitutes a distinct entity, the onset of which is in infancy. Its onset is in the infancy, this Dravet syndrome. It is initially characterized by febrile and afebrile unilateral clonic seizures. Initially what happens? There is a febrile and afebrile unilateral clonic seizures that recur every 1 or 2 months. How are these seizures? They are unilateral clonic seizures. Fine. And these early seizures are typically induced by fever, but they differ from the usual febrile convulsions in that they are more prolonged, more frequent, and focal and recur in clusters. How are they different? That they are more prolonged, more frequent, and focal and reoccur in clusters. Seizures subsequently start to occur with the lower fever and then without fever. Fine. Then they progress. Then they start with the lower fever also, and then without fever also. During the second year of the life, myoclonus, atypical absences, and the focal seizure occur frequently, and developmental delay usually follows. This syndrome is usually caused by a de novo pathogenic variant, although rarely it is inherited in an autosomal dominant manner or may be inherited from a non-affected carrier parent. Variants in the SCN1A gene are the most common cause of the Dravet syndrome, causing 80% of all the cases. The same gene is affected in the GEFS plus spectrum. However, in Dravet syndrome, the variant leads to the loss of function and thus to a more severe phenotype. There are several milder variants of the Dravet syndrome that manifest some but not all of the previous features and that are referred to as the Dravet syndrome spectrum or the SMEI borderline it should be. Rarely the GABRG2 and SCN1B and SCN2A genes may cause the Dravet syndrome. However, in 10 to 20% of the cases, a specific gene variation is not identified. The majority of the patients who had prolonged febrile seizures and encephalopathy after vaccination and who had been presumed to have suffered from the vaccine encephalopathy, seizures and the psychomotor regression occurring after the vaccination and presumed to be caused by it turns out to have Dravet syndrome pathogenic variants, indicating that the disease is caused by the variant, not secondary to the vaccine. This has raised the doubts about the very existence of the entity vaccine encephalopathy. Now coming to the evaluation. In febrile seizures, the figure we will read delineates the general approach to the patient with the febrile seizure. Each child who presents with the febrile seizure requires a detailed history and a thorough general and neurologic examination. Febrile seizure often occur in context of otitis media, roseola and human herpes virus 6 infections and infections with the norvovirus, pericovirus, enterovirus, shigella or similar agents, making the evaluation more demanding. In patients with the febrile status epilepticus, HHV6B more frequently and HHV7 infections may account for 30% of the cases. Okay, so this is something new that I read, that febrile status epilepticus, these HHV6B and HHV7 infections, they account for 30% of the cases. Now coming to the lumbar puncture. Meningitis should be considered in the differential diagnosis and lumbar puncture should be performed for all infants younger than 6 months of age who present with the fever and seizure. Okay, if they are younger than 6 months of age, present with the fever and seizure, what age? Less than 6 months, right? Then lumbar puncture should be done in it. If the child is ill appearing, or at any age if there is a clinical sign or symptom of the concern, fine, then we have to do lumbar puncture. A lumbar puncture is an option in the child 6 to 12 months of age who is deficient in the Haemophilus influenza type B and Streptococcus pneumoniae immunization. Okay, so lumbar puncture, we saw that if less than 6 months of infants with fever and seizure, we have to do lumbar puncture in all. But lumbar puncture is an option in children between 6 to 12 months of age, in infants between 6 to 12 months of age who are deficient in these vaccination of Haemophilus influenza and Streptococcus pneumoniae immunization, for whom the immunization status is unknown. For those also we have to do lumbar puncture. Lumbar puncture is an option in child who have been pre-treated with the antibiotics. In uninfected patients presenting with febrile status epilepticus, a non-traumatic lumbar puncture rarely shows cerebrospinal fluid pleocytosis. Fine. In uninfected patients presenting with the febrile status epilepticus, a non-traumatic lumbar puncture rarely shows CSF pleocytosis, that is 96% have less than 3 nucleated cells in the CSF with a concurrently normal CSF protein and glucose. Pleocytosis suggests bacterial or viral infection. Fine. Now coming to the EEG, that is electroencephalogram. If the child is presenting with the first simple febrile seizure and is otherwise neurologically healthy, a EEG need not to be performed as a part of evaluation. An EEG would not predict the future recurrence of the febrile seizure or epilepsy even if the result is abnormal. Spikes during the drowsiness are often seen in child with the febrile seizures, particularly those older than 4 years, and These do not predict later epilepsy. EEG performed within 2 weeks of the febrile seizure often have a non-specific slowing, usually posteriorly. Thus, in many cases, if an EEG is indicated, it is delayed until or repeated after more than 2 weeks have passed. An EEG should therefore generally be restricted to special cases in which epilepsy is highly suspected, and generally it should be used to delineate the type of epilepsy rather than to predict its occurrence. Fine. So, why should we use EEG to delineate the type of epilepsy rather than to predict its occurrence? If an EEG is done, it should be performed for at least 20 minutes in wakefulness and in sleep according to the international guidelines to avoid misinterpretation and drawing of the erroneous conclusion. At times, if the patient does not recover immediately from a seizure, an EEG can help distinguish between the ongoing seizure activity and a prolonged post-ictal state. After febrile status epilepticus, focal EEG slowing over the temporal lobe increases the chance that the patient may have medial temporal sclerosis on follow-up. Blood studies. Serum electrolytes, calcium, phosphorus, magnesium, and a complete blood count are not routinely recommended in the workup of a child with first simple febrile seizure. They are not routinely recommended. Okay. Blood glucose should be measured initially and with a prolonged post-ictal obtundation or with the poor oral intake. Fine. Blood glucose needs to be monitored. Serum electrolyte values may be abnormal in the children after a febrile seizure, but this should be suggested by precipitating or predisposing conditions elicited in the history and reflected in the physical examination. If clinically indicated, there is dehydration, these tests should be performed. A low sodium level is associated with higher risk of recurrence of febrile seizures within the following 24 hours. This is something new. Fine, that this line is new, that a low sodium level, if present at the time of presentation, then they have a high risk of recurrence of febrile seizure within the following 24 hours. We read it in the risk factors table also. Now coming to the neuroimaging, a CT or MRI is not recommended in evaluating the child after the first simple seizure. It is not recommended. Fine. The workup of a child with a complex febrile seizure needs to be individualized. This can include EEG and neuroimaging, particularly if the child is neurologically abnormal. Fine, when we have to do EEG and neuroimaging when the child is neurologically abnormal. Approximately 10% of the children with the febrile status epilepticus are reported to have unilateral or less frequently bilateral swelling of the hippocampus acutely. If 10% of the child with febrile status epilepticus, they have what? Hippocampal swelling of their hippocampal, either unilateral or bilateral also. Subsequent long-term hippocampal atrophy is evident in about 71% of those who had acute findings. Whether these patients will ultimately develop temporal lobe epilepsy remains to be determined. Now moving on to the treatment. In general, anti-epileptic therapy, continuous or intermittent, is not recommended for children with one or more simple febrile seizure. Fine, we don't have to give them anti-epileptic therapy, either continuous or intermittent also, for children with one or more simple febrile seizures. Parents should be counseled about the relative risk of recurrence of the febrile seizure and recurrence of epilepsy, educated on how to handle the febrile seizures and the recurrence of epilepsy, educated on how to handle a seizure acutely, and given emotional support. If the seizure lasts for longer than 5 minutes, acute treatment with the lorazepam, midazolam or diazepam as needed. Rectal diazepam is often prescribed to families to be used at the home as a rescue medication if a febrile seizure lasts longer than 5 minutes. Fine. At home, what can be used? Rectal diazepam if a febrile seizure is lasting for more than 5 minutes. Alternatively, buccal or intranasal midazolam or diazepam may also be used. In cases of frequent recurring febrile seizure, intermittent oral clonazepam in the dose of 0.01 mg per kg every 8 to 12 hours up to a maximum dose of 1.5 mg per day, or oral diazepam can be given during the febrile illness. Fine. This is very commonly used in cases of frequent recurring febrile seizure, or intermittent clonazepam. In what dose? this 0.01 mg per kg every 8 to 12 hours up to a maximum dose of 1.5 mg per day. Fine. Such therapies help reduce but do not eliminate the risk of recurrence of the febrile seizure. Historically, continuous therapy with the anti-epileptic drugs, phenobarbital or the valproic acid, was occasionally used to prevent the febrile seizure. However, in the vast majority of cases, use of continuous therapy is not justified because the risk of side effects and the lack of demonstrated long-term benefits, even if the recurrence rate of the febrile seizure is expected to be decreased by these drugs. Antipyretics can decrease the discomfort of the child but do not reduce the risk of having a recurrent febrile seizure. Chronic anti-epileptic therapy may be considered for child with a high risk of later epilepsy. The possibility of future epilepsy does not change with or without anti-epileptic therapy. Iron deficiency is associated with increased risk of febrile seizures. Okay, iron deficiency is also associated with increased risk of breath holding spells, and in children with the breath holding spells, treating with the iron in iron deficiency cases helps a lot. Just a different point that I have just noticed in my IPD. So this iron deficiency is associated with an increased risk of febrile seizure, and thus screening for that problem and treating it appear appropriate. A recent Delphi type European study generated specific recommendations for providers to deliver to caretakers after febrile seizure. Reference provided later. These include the definition of the febrile seizure, basis of clinical diagnosis, acknowledging parental stress, risk of recurrence, and a long-term care of the child, which should also include the parents should avoid co-sleeping, which is dangerous for the child and does not prevent febrile seizures. So this happened in Europe, not in India. Okay. This is the treatment algorithm for the management of febrile seizures. We have to first ask about the history, exam, manage the acute febrile seizure and acute illness, first aid, midazolam, diazepam, all the diagnostic tests that needs to be done, and then determine the risk factor for the recurrence and estimation of the risk of recurrence of the febrile seizures. We already saw, right? There was a table given with the risk of epilepsy and all. Counsel the parents about the risk of recurrence and how to provide the first aid and manage fever. Determine the risk factor for the later epilepsy. Low risk, vast majority of the cases, we don't have to give any therapy or investigations are necessary. No investigations basically. And in high risk, minority of the cases, consider EEG and imaging, and consider intermittent or oral diazepam, or in exceptional cases that reoccur, continuous therapy can also be used. Fine. This was all about febrile seizure. In the next video, we will talk about unprovoked seizure. Thank you.